Welcome to APSA's Fetal Diagnosis and Therapy Committee APSASode. I am Ronnie Marwan. I am the current chair of the Fetal Diagnosis and Therapy Committee.
And I'm Daryl Cass. I serve as the vice chair. We're looking forward to sharing this APSASode with all of our members, both here in North America and internationally.
Our APSASode has two parts. Part 1 will include abstract presentations and discussions, and Part 2 will focus on FETO in the management of CDH. Daryl and I would like to invite Dr. Mary Austin from Children's Memorial Hermann Hospital in Houston to moderate Part 1.
Thank you, Dr. Marwan. Our first abstract for this session will be presented by Dr. Sarah Stokes from UC Davis and is titled Long-Term Safety of Placental Mesenchymal Stromal Cells for In Utero Repair of Myelomeningocele in an Ovine Model.
Thank you for the opportunity to present our work. My name is Sarah Stokes and I am a surgery resident at UC Davis. The treatment of myelomeningocele, or MMC, was revolutionized with the management of myelomeningocele study, which demonstrated that prenatal repair was associated with decreased need for shunts and improved motor outcomes compared to postnatal repair. However, despite the improvements seen, 55% of children who were repaired prenatally were unable to walk at 30 months, demonstrating the need for ongoing research to improve outcomes. Our lab has extensively researched placental mesenchymal stromal cells, or PMSCs, as an adjunct to in utero repair. We have demonstrated that when human PMSCs seated on an extracellular matrix, or PMSC ECM, are applied to the spinal cord during repair of MMC in a fetal ovine model, lambs have improved motor outcomes and preserved large neurons in the spinal cord. In this image, both lambs underwent in utero MMC defect creation. Lamb 1 was repaired in utero without PMSCs and is unable to walk. Lamb 2 was repaired in utero with PMSCs and is able to walk. This work has led us towards a first in-human clinical trial of PMSC ECM for in utero repair of MMC. The long-term safety of PMSC application to the fetal spinal cord is not known and needed to be evaluated before proceeding with a clinical trial. The gold standard fetal ovine MMC model consists of staggered defect creation and repair. During defect creation, there is extensive removal of the paraspinal muscles, which results in significant morbidity for the lamb and makes long-term survival challenging. To survive lambs in this study long-term, we slightly adapted this model. We performed defect creation and repair in a single surgery at a median gestational age of 106 days. We performed an L5 to L6 laminectomy without removal of paraspinal muscles, placed the PMSC ECM product directly on the spinal cord, closed the paraspinal muscles, and skinned and returned the fetus to the uterus. 5 fetal lambs underwent surgical intervention. Their 6 siblings served as normal controls. Lambs were delivered via cesarean section at a gestational age of 141 days. Lambs were survived for 3 months after birth. MRIs were completed at birth and at 3 months to evaluate for abnormal tissue formation, tumor formation, and spinal cord tethering. Histologic analysis of all organs was completed to evaluate for tumor formation or any adverse effects. Quantitative PCR analysis was performed to evaluate for human DNA, which would indicate the persistence of PMSCs, as these were derived from human placentas. There was no evidence of tumor formation or spinal cord tethering on any of the MRIs completed at birth or at 3 months. On histologic analysis, there was no evidence of tumor formation or histologic changes to suggest treatment-related effects in any of the examined tissues. There were no lambs in which human DNA was detectable in all 3 triplicate cycles in any of the examined tissues. 1 lamb that had undergone surgical intervention had 2 detectable values out of 3 at the lumbar-spinal cord, and 1 lamb had 1 detectable value out of 3 triplicates at the ECM. These quantification cycle values correspond to a concentration of human DNA that is below the limit of detection of the qPCR and represent nonspecific amplification. They do not indicate the presence of human cells. Our study is limited by the relatively low number of animals and the lack of randomization. It is possible that adverse effects develop after 3 months. However, as we did not identify any persistent PMSCs, this is unlikely. In conclusion, we have demonstrated the safety of the PMSC ECM product in a large animal model for up to 3 months after delivery. This data adds additional support for proceeding with the first in-human clinical trial of PMSC ECM for in utero MMC repair.
We'd like to thank Dr. Stokes, Dr. Farmer, and colleagues for presenting this work and for doing the work. We all know how difficult these larger animal studies can be, so it's great that they're really doing this work and moving the science forward. We have a few questions for you. The first I have is about the study themselves. You've shown the safety of this model for 6 animals. However, is there a gold standard for the number of animals that you need to include in a safety study before moving on to human trials? That's number one. And number 2, is 3 months long enough to prove the safety in these animals and in humans?
Thanks for the questions. So to go for the number of animals first, there's no clear gold standard, and we developed this study in consultation with the FDA. Prior to proceeding with first-in-human trials, we completed this study, and we also completed a mouse study where we evaluated the safety of the PMSE-ECM in 28 mice. Here, our goal was to evaluate the safety when we applied the product directly to the fetal spinal cord. The FDA requested that we do 3 lambs to evaluate that safety study, and because we've previously had a 57% loss rate, we slightly overshot. So we did our surgeries on 7 lambs and we had 5 survive. For the duration of survival, when this is going into fetuses, their life expectancy is going to be obviously longer than 3 months. And so we do want to be sure that it's going to be safe for their entire life. What's important here is that we didn't find any cells remaining at 3 months, so we don't anticipate that there will be any unanticipated complications further down the road.
Great, thank you.
Great. Dr. Stokes, is it possible for human MSC cells that they may behave differently when injected into the human fetal spinal cord?
So it is possible. We're hoping that potentially they're more efficacious when it's going within the same species as opposed to cross species. In terms of their safety, we have previously looked at lamb PMSCs going into a lamb and at lamb amniotic membrane going into a lamb. And we haven't, though we've only survived those to birth, we haven't seen any tumor development or any complications.
Was the method and dose of administration of MSC cells over the spinal cord similar to the previous studies by your group? And if so, how is it, or if not, how is that difference going to affect the uptake of the MSC into the spinal cord?
So the surgeries were slightly different. In our previous studies, we've performed an initial defect creation at L1 to L6 around GA75, and then we've performed a repair 25 days later. In this study, we performed just 1 surgery in which we made a smaller laminectomy, just 2 levels, and we applied the PMSE-ECM and repaired the defect in the same surgery. And we did this so that the lambs would be able to survive long-term, because with such a large defect, it's hard for them to keep on walking as they grow. Importantly, we did put the PMSE-ECM directly on the spinal cord, which is what we've done in previous studies and is what is going to happen in humans. And we also use the same seating density of the cells on the ECM. This is going to be done in humans.
Great, thank you.
Great, and I have one more 2-part question for you here. The first part is what are the next steps moving forward towards human trials? And then the second part is, do you see this technology being used for open repairs, fetoscopic repairs, or both?
So for the first part of the question, completing this study along with the mouse safety study that I mentioned has really supplemented the extensive efficacy work that this lab has done. And we've been approved by the FDA to move forward with in-human trials, and we're currently open for enrollment. Great. For open versus fetoscopic repairs, this is initially going to be used for open MMC repairs, as we've done in animal models. And there is potential to expand this to fetoscopic MMC repairs. The challenge in doing so is going to be making sure that the cells stay on the ECM as it goes in through the port. And that is the next thing that our lab is going to be looking at.
Great.
Wow, that's really cool stuff.
Thank you very much, Dr. Stokes. Appreciate it. Great presentation.
Thank you.
Thank you.
Thank you.
Our next abstract will be presented by Dr. Amanda Louiselle from the University of Colorado and is titled Intraoperative Use of Patch for Myelomeningocele Closure and its Effect on Postnatal VP Shunt Placement.
Hello, my name is Amanda Lewisell, and today we'll be discussing myelomeningocele, or MMC closure with a patch, and its effect on postnatal ventriculoperitoneal, or VP shunt placement. We have no disclosures. Fetal repair, as opposed to postnatal repair of MMCs and myeloschisis, has shown improved neurologic outcomes. The size of the defect can vary significantly, and although some may be closed primarily, some require a patch to allow the delicate fetal skin to close without tension or tearing. However, use of these patches risks a non-watertight closure, which could lead to ongoing cerebrospinal fluid leakage through the defect. This can affect hindbrain herniation, or HBH, ventricle size, and the need for postnatal VP shunt placement. We performed a retrospective review from 2013 to 2020 of all patients that underwent fetal MMC or myeloschisis repair at our children's hospital. Repair types were divided into non-patch, which included primary closure and myofascial closure, and patch. We performed several statistical analyses using different variables and models. We had 85 patients that fit our criteria, 40 of whom did not require a patch, and 45 that did require a patch to repair their defect. There was no significant difference in maternal age at the time of repair, maternal BMI, maternal gravidity, or the number of spinal levels affected by the defect between these two groups. Intraoperatively, the only significant difference between the two groups was defect repair time, but total procedure time was not altered. There was no significant difference in fetal or maternal blood loss, and intraoperative adverse events occurred at the same rate for both groups. Looking back at the fetus's preoperative MRI findings, we found that those that required a patch had a larger defect length and surface area. They were also more likely to be diagnosed with myeloschisis and were slightly younger at the time of surgery. Interestingly, defect width and the length to width ratio were not significant in determining the need for patch placement. 2 weeks after fetal repair of their defect, patients underwent another MRI. And what this showed for the patch group was that there was significantly smaller ventricular atrial diameter in this group. However, there was more hindbrain herniation in this group, which is indicated by the more negative number in the patch column. Additionally, there was less change between the preoperative and postoperative MRIs in the patch group. So the purpose of the study, and the question that we still had yet to answer, was, even though we're seeing less hindbrain herniation, does this mean that there's going to be decreased VP shunt placement in the postnatal period? And thus far, our analysis has shown that these do correlate. For patients that did not require a VP shunt, they had less hindbrain herniation, indicated by the less negative number in that column, and had more change in their hindbrain herniation when comparing their preoperative and postoperative MRIs. So in conclusion, preoperative imaging is useful in predicting the need for patch placement. Patch placement causes significantly less, or is associated with significantly less, improvement in hindbrain herniation, which predicts the need for postnatal VP shunt placement. The cause of this worsened hindbrain herniation is unknown, but may be related to porosity of the patch, dehiscence, or patch breakdown. Thank you for taking the time to listen to our presentation, and I'd be happy to take any questions at this time.
Dr. Lewisell, thank you so much for your great work and for including us in this discussion. I'll start by asking you, how did your team decide which patients to use a patch for? And was there consistency in the fetal and neurosurgical team across all patients in the cohort?
Yeah, absolutely. Great question. So we have a multidisciplinary approach at our institution where we meet with each of the patients beforehand, and that team consists of fetal surgeons, neurosurgeons, maternal fetal medicine physicians, genetics, social work, and some of the other ancillary services. And we meet with all of them individually and then come together at the end with our fetal neuroradiologists and discuss preoperative planning, whether or not we think we're going to need a patch or any other special considerations for that fetus that might be necessary during the time of the operation. Occasionally we will, we've started using, a 3D model with our bioengineering department to try and predict those that might need a patch or kind of how their operative repair will look.
Dr. Lewisell, excellent work to you and your team in Colorado.
Thank you.
My question for you is to clarify your abstract in terms of the patch that you used. This was a skin patch. Did any of your patients receive a dural patch? And did you look at the effect of a dural patch on hindbrain herniation or VP shunt rate?
So about 15% of our patients did not require a dural patch. That decision was made by our neurosurgery colleagues at the time of the operation. That was the times when we didn't use the dural patch was a little bit earlier on in the cohort study. In the past couple of years, we've almost always used a dural patch for the repairs. We have not looked specifically at dural patch, kind of dividing those two groups with regard to hindbrain herniation or the need for VP shunt placement, but I think that would be an interesting avenue to take with this data. Since we have the data, we might as well look at it from every angle possible.
So you move towards using a dural patch on everybody now in your repair, is that right?
Correct.
Great. My other question for you is, did you look at the rate of VP shunt placement for those that received a patch versus no patch directly, meaning skipping the hindbrain herniation aspect, patients that received a patch versus those that didn't, and what their outcome was in terms of VP shunt placement, and was that significant if you did look at it?
So that was our initial goal, was to make that direct correlation. Unfortunately, we did not find statistical significance with that direct correlation, which is why we took the route of looking at hindbrain herniation and other MRI findings to see how those correlated preoperatively, postoperatively with the patch, no patch, and VP shunt, no VP shunt. So the significance, I think, will come with time. Just the numbers alone, if I'm remembering correctly, of those that had a patch, 18 had a VP shunt, 21 did not. And then of those that did not have a patch, 11 had a VP shunt, 18 did not. And then of our myofascial closures, of which we only included 5 in this initial study, now we're closer to 15, 16. One of them required a VP shunt and 4 did not. So I think with enough patients, we will see statistical significance, but right now it is not there.
Dr. Lewisell, that takes me to our last question for you. Speaking of the myofascial closure, some centers advocate that myofascial closure and large closure without a patch, even if it may require relaxing incision, is the way to go. Do you plan on making any changes for your technique? And it seems like you're already heading towards that direction.
Yeah, absolutely. So the past, I would say 18 months, we've almost exclusively done myofascial closures. Like I said, we have about 15 or 16 patients now that we are hoping to look at kind of in a separate paper, separate set, and look at their VP shunt placement at 6 months post-operatively. So almost exclusively now we're doing a dural patch and then a myofascial closure. And thus far, based off the MRI findings, we're finding success, but we obviously want to correlate that to VP shunt placement down the line for these patients.
Excellent presentation. Thank you from both of us.
Thank you.
Our final abstract for this session will be presented by Dr. Marissa Schwab from UCSF, and it's titled Long-Term Neurodevelopmental Outcomes After Fetal Transfusions for Hydrops Fatalis.
My name is Marissa Schwab. I'm a surgery resident at the University of California, San Francisco, and I'll be applying into pediatric surgery this year. Today I'm going to present the long-term neurodevelopmental outcomes after fetal transfusions for Hydrops Fatalis. Hydrops Fatalis, defined as abnormal fluid in 2 or more compartments, has many etiologies. I've highlighted some of these etiologies, several of which have fetal treatments available on this slide. And the common denominator for all these pathologies is that we think all cause patients to develop brain hypoxia. So this is why we focused on the long-term neurodevelopmental outcomes after fetal therapy in fetuses with hydrops. We chose to focus on one of the hemoglobinopathies, alpha thalassemia major. As our model, because we have an ongoing trial of in utero stem cell transplantation for fetuses with alpha thalassemia, and because we have a homogeneous set of patients with alpha thalassemia who are treated in utero but with blood transfusions that we could test for their neurodevelopmental outcomes. So fetuses with alpha thalassemia typically have hydrops, and unless they're treated in utero with serial blood transfusions or IUTs, they have a very high rate of mortality. But when treated with serial in utero transfusions, the hydrops resolves and they have excellent outcomes. So it was a good model that was applicable to other causes of hydrops that may resolve with other types of fetal therapies. So in our cohort of patients that I'll be describing, they received a median of 5 IUTs beginning at 24 weeks gestation. Every single fetus had hydrops which resolved with serial IUTs. And patients were born at a median 37 weeks gestation and were aged 1 month to 11 years old at the time of neurotesting. So to evaluate the neurodevelopmental outcomes, we use the Vineland-3. And the Vineland-3 is a diagnostic neurodevelopmental tool that's been widely validated across many different pediatric patient populations. It can be virtually administered to patients of all ages. A score is generated for each of the 4 subsections, so communication, daily living skills, socialization, and motor skills. And an aggregate overall score is then generated and compared to an age-matched US population. So you end up with a percentile, which is what I'll be presenting. So each dot on this plot corresponds to a single patient. The x-axis is the gestational age at first in utero transfusion, or IUT, and the y-axis is that overall Vineland percentile score. So as you can see, early gestation age at the first treatment correlated with improved neurological outcomes. We had one patient here in the open circle who was transfused immediately at birth at 28 weeks, and that patient had the worst neurodevelopmental outcome. And the Vineland percentile is based on a Gaussian curve, so a percentile less than 2 standard deviations, shown in red here, is considered developmental delay. So none of our patients had any developmental delay. So in conclusion, fetal transfusions in patients with alpha thalassemia reverse hydrops and result in normal long-term neurodevelopment. Earlier onset of fetal therapy improves neurologic outcomes. And we think the Vineland could be a useful tool to evaluate survivors of hydrops due to other causes. Please feel free to contact me or Dr. Patipi McKenzie at our emails listed here. I'd like to thank all the families who participated, Dr. Gano, CERM, the UCSF Center for Maternal Fetal Precision Medicine, and the NIH Favor T32 grant. Thank you very much.
All right, Dr. Schwab, thank you so much for giving us a chance to discuss your abstract. My one question for you is, how do you attribute the neurodevelopmental outcomes to the fetal transfusions? Were there any thoughts given to comparing those who did receive fetal transfusions to those who did not receive any fetal therapy?
Yeah, thank you for your question. We hypothesized that the fetal transfusions allowed adequate oxygenation to the brain and so translated to an improved neurodevelopment. But the reason we're unable to compare those who have received fetal therapy to those who have not is that alpha thalassemia is typically a fatal disease at or shortly after birth if the patient doesn't receive fetal therapy. And so the true denominator of untreated patients with alpha thalassemia is really unknown at this point. We did have one patient who was only diagnosed and thus transfused at birth when she was born at 28 weeks gestation, and her Vineland was in the 13th percentile. So it's a little bit difficult to know what impact her gestational age versus the fact she didn't undergo any fetal transfusions had on her neurodevelopment.
Thank you.
And so, Dr. Schwab, can you tell us a little bit more about the Vineland score? I know that it's been widely described and used, but some populations have found that it's got a high specificity and low sensitivity to detecting developmental delay. Can you tell us a little bit more about how you validated the Vineland score in your population?
Yeah, when we were designing the study, we worked with a pediatric neurologist who focuses on fetal neurodevelopment because we wanted to identify which would be the best tool to use in this study. And while we did consider other tools such as the Bailey Infant Scales of Development and the Wechsler Intelligence Scale, We chose the Vineland because it can test children of all ages, from birth all the way up to adulthood, and it can be administered by any clinician. So you don't have to be a trained neurologist or neuropsychiatrist to do the study, and it can be done over the phone or over Zoom. It doesn't have to be done in person. So we felt that it was a more feasible tool in our international cohort of patients. And in addition, we actually started this study at the very beginning of lockdown in March 2020. So it was a much more feasible tool. And we also felt that it was a tool that could be used in other patient populations for who fetal transfusions or fetal therapies are available. So we thought this would be a good model that others could use for patients with other diseases. And like you said, the Vineland test has not been validated in patients with alpha thalassemia, but it has been validated in patients with other hemoglobinopathies such as sickle cell and beta thalassemia. So we felt that it was appropriate to use in our alpha thalassemia cohort.
Well, thank you, Dr. Schwab. Congratulations on a very interesting abstract, and we look forward to hearing more from you and your group.
Thank you very much.
All right, now let's shift gears and focus on the next portion of FETO. Our first speaker is Dr. Sandeep Keshwani from Texas Children's Hospital, who's going to review the biology of FETO. Dr. Keshwani?
All right, Keshwani Basic Science. Hi, my name is Sandeep Keshwani, and I'm a pediatric surgeon at Texas Children's. It's my pleasure to be talking to you today about the scientific evidence for fetal tracheal occlusion in the treatment of congenital diaphragmatic hernia. Now, just like many of the things we do in pediatric and fetal surgery, the study of tracheal occlusion is based on a long history of basic and translational research. And as you can see from this timeline, it's been studied for almost 25 years. Now, this group certainly needs no introduction into CDH and the fact that the majority of morbidity and mortality is due to the associated pulmonary hypoplasia and pulmonary hypertension, not the diaphragmatic defect. But so to briefly revisit the pathophysiology of these changes in this disease, in the airways, these patients have decreased branching morphogenesis, which is associated with lower alveolar counts and lower pulmonary compliance. This leads to an increased sensitivity to baro or volume trauma and an overall decreased pulmonary reserve. Now, similarly, in the arteries, there are changes where there's an increase in arterial muscle thickness or the wall of the vessel, a decrease in the number of arteries, and an increase in pulmonary vascular resistance. Taken together, this results in decreased gas exchange, which is the hallmark of this disease. Now, pulmonary hypoplasia is also related to biomechanical forces. There are normally occurring biomechanical forces from both the fluid produced by the lung and fetal respiratory movements that you can see here in this cine that are essential for normal pulmonary development. And in fact, when these forces are perturbed, such as when there's not enough amniotic fluid or oligohydramnios, or when fluid is taken out of the lungs experimentally in utero, or if there's no breathing movements, such as when the phrenic nerves are cut, these all end up with hypoplastic lung development. Conversely, if there's too much fluid, as when we see in congenital tracheal obstruction, there's actually hyperexpanded or hyperplastic lungs. So the role of biomechanical forces gives logical rise to the use of fetal tracheal occlusion in an effort to grow lungs. Now, this was first noted back in 1965, where tracheal ligation was shown to prevent the egress of lung fluid, which then promoted lung growth. And it was actually Jay Wilson who raised the concept of using fetal tracheal obstruction for the treatment of CDH. So let me share with you some of the highlights of what effects tracheal occlusion have on the pulmonary airways and pulmonary vessels. Now, a lot of the work, as you can be expected, was done in animals. Tracheal occlusion has been shown to increase lung dry weight and airway branching morphogenesis. It also stimulates alveolarization and promotes actual overall maturation of the alveoli. This results in an increase in total air exchange parenchyma to values that are similar to normal lungs. It does, however, promote the apoptosis of type 2 pneumocytes, which you'll remember makes surfactant, but that effect is attenuated when tracheal occlusion is done later in gestation or when there's time left in the in utero period after the occlusion has been removed. So this, coupled with the fact that the effect of tracheal occlusion on lung growth is more pronounced during the saccular phase or the later stages of lung development, provides a fundamental basis for using tracheal occlusion in congenital diaphragmatic hernia, the gestational age when we apply it, and the duration of the occlusion. Now, similarly, there have been effects that studied on tracheal occlusion on pulmonary arteries. Tracheal occlusion reduces the percent thickness of the pulmonary artery wall. It also corrects associated blood flow abnormalities, has been shown to decrease the resistance in pulmonary arteries. Now, as part of the potential mechanisms of these findings, tracheal occlusion has been shown to increase the expression of VEGF. So now all of this correlates with the fact that in human studies, patients with severe CDH that underwent tracheal occlusion have resolution of their pH by 1 year after birth that's comparable to patients with a mild CDH and significantly better than those patients that actually have a severe CDH that go untreated. And you can see that data in this graph. So in summary, tracheal occlusion in CDH promotes lung growth, alveolarization, and maturation. The release of tracheal occlusion at a later gestational age diminishes the deleterious effects on type 2 pneumocytes. It also induces pulmonary artery remodeling, but its effects on CDH-associated pulmonary hypertension are still yet to be fully recognized. Taken together, there is a significant basic and translational evidence for investigating tracheal occlusion and regulating both pulmonary hypoplasia and pulmonary hypertension in CDH-affected lungs. And hopefully you find that this sets the stage for the rest of our program today. Thanks for your time.
Next, we have two speakers, Drs. Mary Austin and Tony Johnson, both from Children's Memorial Hermann Hospital in Houston, speaking about technique of fetal placement. Doctors?
This video will demonstrate balloon placement and deployment for fetoscopic indiluminal tracheal occlusion. This slide depicts the instrumentation needed for FETO balloon placement and deployment. The fetoscope is a 1.3 millimeter fiber optic endoscope housed within a curved 3.3 millimeter sheath. The delivery catheter is loaded with a detachable inflatable latex balloon with an integrated one-way valve and is passed through the working channel of the endoscope. It is important to note that the delivery catheter and balloon are used off-label under an FDA investigational device exemption, as they were originally designed for endovascular occlusion. The technique utilized to access the fetus is similar to the technique used for fetoscopic placental laser coagulation. The procedure is performed in the operating room with sedation and local anesthesia. The patient is positioned supine with a bump under her right side to prevent cable compression. It may be necessary to manipulate the fetal position externally to achieve an optimal position to allow fetoscopic access to the fetal mouth. After the fetus is positioned, fetal anesthesia is administered intramuscularly to the fetus using a 22 gauge needle. The patient is then prepped and draped in a standard sterile fashion. The planned insertion trajectory is infiltrated with local anesthesia. After positioning, a small skin incision is made and a 10 French trocar is inserted into the uterus under ultrasound guidance using the Soldinger technique. It is helpful to introduce the cannula perpendicular to the tip of the nose such that the target area for the endoscope is between the tip of the nose and the mouth. This is a fetoscopic video of a feto balloon placement and deployment in a patient with severe CDH at 28 weeks gestational age. On the screen left is the view with the scope, and on the right is the view via ultrasound. It's important to have both monitors set up such the operating surgeon can see the scope and the ultrasound views. The scope is introduced through the cannula and advanced into the fetal mouth via both direct visualization and ultrasound guidance. The landmarks are the tongue, superior in this view, and hard palate, inferior in this view. After entering the mouth, normal saline flush is used to open the posterior oropharynx and airway. You then visualize the epiglottis followed by the vocal cords and carefully advance the scope beyond the vocal cords. After visualization of the carina, advance the catheter with the balloon and instill the balloon with normal saline. As you withdraw the catheter and scope, the counterpressure deploys the balloon, which is then visible within the fetal trachea on ultrasound. The average operative time for the procedure is 10 minutes, but there is significant variability with reports between 3 and 93 minutes. Longer operative times are usually related to suboptimal position of the fetus and are associated with an increased risk of premature rupture of membranes. Polyhydramnios can also increase fetal mobility and make positioning difficult. In these cases, it may be helpful to perform an amnioreduction prior to attempting fetal placement. If you're unable to achieve an acceptable fetal position, it may be helpful to abort the procedure with plans to return at a later date. Failure rates for balloon placement are less than 4%. Thank you very much.
Next, we have Dr. Olyinka Olatoya and myself from Nationwide Children's Hospital and Cleveland Clinic reviewing techniques of feto reversal.
My name is Yinka Olutoye, and with me today is Daryl Cass. And together we're going to briefly discuss fetal balloon removal for tracheal occlusion in fetuses that have undergone tracheal occlusion for congenital diaphragmatic hernia. Daryl, how about you give us a brief presentation on the topic?
Thanks so much, Yinka. So obviously the first reason we need to remove this balloon is to permit the baby to be able to breathe once they're born. But a second benefit is the restoration of type 2 pneumocytes for surfactant production, which has been demonstrated experimentally in multiple animal models. So there are 4 ways that the balloon can be removed. The most common and preferred is a fetoscopic balloon removal. A second that's often used in some centers more than others is ultrasound-guided balloon puncture. If you don't have time, you can do an exit to removal. And in some instances, we do a modified C-section to removal. And the least desirable option is postnatal removal, which requires urgent bronchoscopy or balloon puncture. The technique for the fetoscopic balloon removal is exactly the same as that for fetal placement. We use the same operative sheath. This is a video that was very nicely donated by Dr. Tony Johnson in Houston. There's the epiglottis. There are the vocal cords. That's how they look in the fetus, as we've seen from the fetal placement. These are the cords again, and now the trachea. And here's the balloon. There's a grasping forceps being placed in a working channel. The balloon is brought up to the scope and then it's popped. And now the parts are extracted. So this slide briefly talks about the pros and cons of the different strategies. Fetoscopic permits a controlled removal of the balloon and its parts. A con is that it is slightly larger uterine access and the need for the instrumentation in a procedure suite. In contrast, an ultrasound-guided balloon puncture has a slightly smaller puncture of the membranes and requires less instrumentation, but there is a risk to nearby structures such as the carotid arteries. The balloon fragments and valve might be aspirated and there's a lower success rate. An exit to removal is much preferred compared to postnatal removal, but has the cons being risks associated with an exit procedure, such as uterine bleeding and atony, and the associated surfactant deficiency, and postnatal should be the absolute last resort. There was a review published about 4 years ago from 3 major centers in Leuven, Barcelona, and Sao Paulo that had a very large number of fetuses that underwent balloon removal. There were no maternal complications. 28% had ruptured membranes prior to the removal procedure, and it demonstrated that ultrasound-guided puncture was less successful than fetoscopic removal. When the procedure is done emergently, there's a much higher need for an exit procedure. And there was a paper published several years ago that demonstrated the point about the timing of balloon removal and delivery. And those that survived to discharge, there was a much longer interval between balloon removal and delivery compared to those that later did not survive. and it seems to be important to have at least 1 day prior to delivery. So in summary, elective fetoscopic removal is the preferred approach, though ultrasound puncture is an option. Removal prior to delivery permits recovery of type 2 pneumocytes and surfactant production, which is associated with increased survival. Thank you so much.
Well, Dara, thanks for that quick presentation. It's important that in most places, fetoscopic removal is preferred, but obviously in emergent scenarios, each institution would perform whatever is most suitable in their hands, either the balloon puncture or the fetoscopic removal or an exit procedure. For those that are doing the postnatal repair, it's important to realize though that at that stage, the balloon is probably loose within the lumen. And so just trying to puncture it without grasping it first makes it tricky. And so having a forceps in place to grasp it before puncturing the balloon is going to be key. But an important aspect of reversal of the tracheal occlusion in fetus is with CDH.
Thank you so much, Inka.
Thank you all for a terrific session. It is evident that despite the great advances in this field, we are only just scratching the surface here.
I agree. How exciting. I think the future is very exciting in the management of fetuses with diaphragmatic hernia.